Good evening, Dr. Goyal.
He's joining me.
Yeah, he's joined it. Good evening, Dr. Goyal. How are you, sir?
Good evening. Good evening. कैसे हो उमा?
Good, sir. Good, sir. Good to
हाय
see you.
सर जी कैसे हैं?
कैसे हो बसक?
हाँ बहुत अच्छा माय सीनियर रेसिडेंट
सभी लाइव
Dr. Atul?
Yeah.
Please.
Are we live?
Yeah, we are live now.
Okay. Good evening, everyone. On behalf of Noida Ophthalmological Society, I extend a warm welcome to our esteemed guest speakers, Dr. Samar Basak and Dr. Rohit Shetty. They will be giving us their insight into the corneal aspect of ophthalmology, and Dr. Basak will be enlightening us with the endothelial keratoplasty, and Dr. Rohit Shetty will be shedding lights on the artificial intelligence related to the refractive surgery. So without wasting any time, I will request Dr. Ajay Arora, our secretary, to initiate the proceedings and introduce the speakers.
Hi, good evening, everyone. So welcome back to the monthly webinars of Noida Ophthalmological Society. This is our 8th webinar, which we started in February 2021. And it's my honor to welcome my friend, Dr. Samar Basak and Professor Rohit Shetty, who have been, are the stars of Ordinary Ophthalmic Society as well as International Ophthalmology. We have two sessions. The first session is invited talks, first by Dr. Samar Basak, followed by Dr. Rohit Shetty, and then we have case discussions. Dr. Uma, who is the head of the Department of Corneal Services at Eye Care Hospital, is going to moderate the session. So over to you, Uma. Please go ahead and introduce Dr. Samar. After Dr. Samar's talk, we'll have a small discussion followed by Dr. Rohit's talk. Over to you.
Jay, it is my honor and pleasure to introduce Dr. Samar Basak, who does not need any introduction. I hope you can see just one second. Can you
share it, Uma?
I'm just sharing that. Yeah, I'm doing that. Yeah. Is that slide now visible? I think it's coming through. So, Dr. Samar Basak is the founder, director, and HOD of Cornea Services in Disha Eye Hospitals, Kolkata. He is a recipient of several awards, amongst them 9 awards from AIOS, an LP Agarwal Oration Award, Senior Achievement Award at AIOS, American Academy 2015, Best Video Award 5 times in American Academy, twice at ESCRS, Best Video Award at ASCRS 2015, Best Paper on Cornea, American Academy 2020, Dr. P. Shivareddy International Award at AIOS 2021. He has authored 8 books. His books are wonderful. On cornea, they are wonderful atlases also. He has 44 papers in peer-reviewed journals. His special interests are endothelial keratoplasty, keratoprosthesis, ocular surface disorders, complicated cataract surgeries. He has done more than 20, maybe even 30,000 cataract surgeries. And he's an expert at phaco, small incision cataract surgery, and does very, very complex surgeries. So over to you, Dr. Samar, we're looking forward to a wonderful talk.
Thank you, Uma, for your kind introduction. I am sharing my screen. Is it visible now?
Yes,
Yes,
sir.
sir.
Make it a full screen. Yeah,
And thank you, Dr. Atul, Dr. Ajay, and all executive members of Noida Ophthalmic Society, and my senior resident, Dr. Jael Goel. And this is a wonderful opportunity to share some knowledge with you. I do not have any financial interest on this talk. I have give the title little different, PK, EK, and beyond, because Uma was asking little more than EK. So I must acknowledge my patients, some good YouTube videos, my cornea colleagues, our iBank staffs, and other colleagues for referral. Also, I acknowledge my daughter who believes We live in the newness of small differences, and it inspires me. And stories will forget their beginning, and in forgetting, will eat other stories. But then, few years from now, things may be different. So, Rohit will probably talk about those things. So, I just start during my PG days 84-87 at RP Center as a PG student. My thesis on a modification of MK medium and experimental study with dog's cornea. Probably the first person in India who used MK medium. I personally used to enucleate plenty of dogs' eyeball from New Delhi Municipal Corporation with the help of eye bank technician Mr. Beast. And they used to kill the stray dog by electrocution. And that helped to grow my interest in eye banking. During my PG days, opportunity to observe and assist few cases of PK, surgeons were led Professor Madan Mohan and Professor Anita Panda. Both are my thesis guides. No video display at that time. And used to practice suturing in the wet lab under microscope with my dog's cornea because I used to have plenty after the clinic hours. In winter, in 5th semester, one night, I had an opportunity of doing one PK in a keratoconus patient under the guidance of Professor Anita Panda. This was an awkward beginning because that time PG students are not allowed to do any PK. Those days, it has to be used within 24 hours and most PK surgery happened at night. I had another opportunity of doing PK within a month with madam only. I joined as senior resident in cornea unit in January 88, but resigned just after 10 days and left RP Center for personal health reason and family pressure. And that was the end of my dream with cornea and PK learning. In 88, I took government health service job, so-called secure job, and posted as a village medical officer. 93, for 5 years, I didn't have any exposure to ophthalmology except some OPD patient of my own interest. 93, I was posted as a so-called senior resident in eye department in my own college. There I discovered an eye bank, which was locked for 7 years. And I found 2 operating microscopes, all functional, but no faculty was using them. I grabbed those opportunities. Started reading 2 classical books on PK, that time the T.A. Cassay and Brightbill. 93 to 97, I performed 122 PK in NRS. Freehand, free self-learning. The only person was doing PK in the department. Restructured the eye bank to have more voluntary donation. I used to call the I shop myself, I evaluate, that means cook myself, and I eat myself. All myself only, no technician, no one was there beside me. State regional meeting, I used to show my results to have more referral. 97 again, when I get the lecturer job, I resigned and joined hand with the friends to have Disha Eye Hospital on 1st May 97. From the very first day, we started our own eye bank and a separate basic cornea clinic. In 97, I did only 2 PKs, one optical, one therapeutic PK. That time I realized that unless we have a quality and robust eye bank, we cannot deliver good cornea services. So if you see our cornea unit, that 97 to 2004, we have a moderately little collection. But when we joined with ACRP with the government, then it has a huge escalation of collection and utilization at the level of close to 1900 and utilization 1300, 1400. And if you see the chronology, that last 10 years, we did more than 13,000 keratoplasty in our hospital. But in the first 10 years, we had done only 1,100 keratoplasty. So far, we have now close to 15,000 keratoplasty by 10 surgeons. So back to my journey, 2002 onwards, every year I used to attend AO meetings. This exposure actually has opened my eyes, grafting beyond PK. Initially started with ALK, DALK in 2004, then DISEC 2006, then gradually Boston K-Pro, Boston Type 2, now all in our armamentarium. No formal training, no fellowship, no particular mentor in my case. Some good tips from my 3-4 best friends over telephone or chat via WhatsApp. So 25 years back, the only option for PBK or Fuchs was PK. But we all know the disadvantages of PK. The one thing is that huge irregular astigmatism. There are other disadvantages. We know that actually gives the problem of graft survival issues. So long-term graft survival is a problem with PK. So that then the evolution of endothelial keratoplasty came, I realized in 2002 after going in American Academy. And you know that gradually it has from PLK, DILEG, DISEC, DSAK, then DIMEC. And in 2011-12, that is the landmark year where actually EK surpluses PK in US. And that is the year we used to celebrate that EK has taken upper hand than PK. And this is for quality of vision, quality of life, and long-term graft survival. If you see this picture, this is a chest X-ray. It has got 3 wires. One in the right-hand side that is there for 34 years. Right-hand side, there are 2 wires. This is 14 years. And there is a unit. It is for 4 years. So this is my X-ray chest. And that is why long-term word is very close to my heart since November 87. So in American Academy, I saw in 2003 several videos. Then again in 2004, that time it was DILEC, but 2004 it was manual DISEC. I took an wet lab course in DISEC in the American Academy. The course fee was very high, $375 US. Only 2 peaks cornea. Only one chance to practice. Mentor was Mark Terry. And he fortunately gave me a free pass for a breakfast course on the same year. And actually that is the beginning for my EK learning. I bought 2 artificial anterior chamber and 1 set of lamellar dissection that year. And 2006, May to June, wet lab after cataract season is over. May, June, I used to start practicing with Goat's whole globe and Goat's sclerocorneal rim. 5 surgeries per wet lab, almost 50 wet lab procedure in 6 weeks. Then I designed lamellar dissection at the same time. And because that time there was no YouTube video, no free video, website, no masterclass, no mentor, no webinars that time. And in 22nd July 2006, performed my first DISEC. It was not at all an ideal case. Nobody taught me that what should be the ideal case in the first cases. The first case was a phakic polymorphous corneal dystrophy and young patient. But fortunately that surgery went well and patient recovered with 6/9 part vision. Then 2nd, 3rd, 4th, up to 10th case in a row within 4 weeks, and shared to show these 10 cases with good results in different local conferences to have more referral. 2006 November, again in Las Vegas, I interacted with Professor Terry and Price to get some tips during the poster session. That is the great area of learning in American Academy. It is not happening now in the last 2 years. Attended all disaccelerated symposium, watches all video, whatever available, several times. DISEC life was then smoother than before. Since 2000 December, 2006 December, I get referral from colleagues from Bengal and Bihar. If you see the EK, the shifting towards DMEC is happening. From DSEC, it is gradually receding from 2014, and DMEC is gradually increasing from 2011 onwards. In India, probably 100 plus surgeons are doing EK regularly for last 10 to 15 years. And probably we are doing 5 to 6,000 DSEC or DMEC per year. We do not have exact data. So if you see the difference between DSEC and DMEC, there is little different. In DSEC, we took also posterior lamella along with DM and endothelium, whereas in DMEC, it is just anatomical replacement of disease DM endothelium complex with the healthier DM endothelial complex from the donor. So this is the difference. Same patient in the right side, if you see, this is DSEC with phaco post-op 9 years. And DSEC, and this is post-op, probably this is 5 years, and with good cell count, and this is anatomically perfect in the left side. If you see the indication of EK as a whole, so it is endothelial dysfunction. So in the Western world, the commonest indication is FECD, Fuchs dystrophy, whereas pseudophakic corneal edema, bullous keratopathy is around 15 to 20%. Failed cases is another 10-15%, and others are miscellaneous cases. Whereas in India, the EK indication, PBK is just reversed 75 to 80%. FECD is 15 to 20%, and miscellaneous maybe around 5%. But surprisingly, I see more FECD in Eastern India than the other part of the country. It is close to 36% in our part. We are doing some genetical study with US collaboration and also Government of India collaboration with FECD patient. We get any clue or not. So DSEC is I always prefer to do manual graft preparation because this is simpler, this is cheaper, and this is reproducible over and over again. So this is my usual artificial anterior chamber, Catina's one. And I used to bought every year from American Academy earlier. And it is manually. So initially you give incision with the blunt dissector. Then this is the indigenous lamellar dissector. You go side to side. And so the one thing is that you have to lie in the posterior surface parallel. If you see that arrow is marking that it's so when you go on the other side, you should be tilting your hand. Whereas the lamellar automated dissector is just like making a LASIK flap and no excitement in it. You just do a flap and it takes 350 or 400 micron blade to have a cap, anterior cap, and this is an open dissection, whereas the manual dissection is a closed dissection. So in both the cases, both DSEC and DMEC, DM scoring is one of the important steps, though in DSEC you can do non-desperate stripping and DSEC, but in DMEC it should be little larger. So you can do under dilated people with trypan blue staining or under air. And normally the graft size is, in DMEC, it is little larger than the DSEC. And in DSEC, we have several techniques. I used to have this forceps technique, taco technique, and also needle technique. I used Busin. I was not comfortable with multiple, AC maintainer and all these things. So I want to finish the surgery very fast. So usually it takes around 15 minutes in my hand. So we do centering and you keep the air bubble for 10 minutes or so, then release it and exchange with BSS and air. And patients usually do fine. Since 2006, I have done more than 1300 dissect procedure, and probably 10% of them are automated. This is by public demand. We have a microkeratome. People rarely used it because it is costlier. And you see that it is giving consistently good results of your manual dissection, manual dissect. I have compared my results with the international results. Though both are same and published. The endothelial cell loss in manual dissect is also similar when I compare with other series. And this is one particular patient I want to show you that this is my third dissect in August 2006. This was seen just last July month, and the patient is doing excellent with very good results. The only thing that there is heterochromia. Now DMEC. I did my first DMEC in 2009. And that video awarded the Best of Show award in American Academy. But that happened without much understanding. Then a failure of 5 eyes out of 8. Then several attempts, more failure. Again, back to only dissect. Wet lab tried every year, but little time, and discontinued every year several times. Then restarted in April 2016, and now we have lots of YouTube video. People are sharing their knowledge. They are opened up their mouth, and they are giving tips. So better understanding of DM scroll, its behavior, anterior chamber fluid dynamics, and more importantly, the SMART, unfolding easier. Surgery is going on smoothly and also in challenging cases. This SMART make the life easy. It represents that it is stromal site, it is severe, it is smooth, and successful surgery. My initial cases are very typical, so I should not lose one particular case. But in writing prescription, I used to write DMEC/dissect, no active marketing for DMEC to the patient. My initial donor selection, because now I know which donor will be. So initially, I was not careful about that. Now people share that. But for initial cases, you should have standby optical quality tissue and try to keep extra time. Surgery time with experience, it can be reduced to 15 minutes only for DMEC, and DMEC triple, it may be within 20 minutes. So I made homemade injection. I never used any goiter or other type of glass injector because again, expense is a thing I always care. This is simple, just saline tube, and here 40 IOL cuttings, that is for sensor multipiece. And you just break it. Every day you make a new one for every surgery. So there is no question of sterilization and no question of breakage of 16,000 rupees glass cannula, which people are using. But the results, if you use only one method, one particular technique, it gives you the best result after some cases. So inferior PI is mandatory in DMEC, and a thorough anterior chamber wash is necessary. So you can do with a vitrector, check your PI site, and then you give a air tamponade, because sometimes in some cases, blood oozing is there from PI site, and some cases you can do YAC PI 7 days prior to surgery if the cornea is clear beforehand. At this particular point, when the air is inside the AT, because that 5-6 minutes time I get, that time I prepare the donor tissue. It is again a simplified technique. I describe it, published it, and if you see that, it is the easiest part of DMEC. Donor dissection is the easiest part. If I teach you, you can do from second or third cases. There are certain tips, and normally the 8 millimeter graft is very important in these cases. And then when you completely separated the graft, trypan blue staining, shifted to a petri dish, and then transferred to your injector. Then I tried to see the scroll behavior. I have also presented a video in American Academy on this. Different types of scrolls are there, and this is the usual technique. My incision is little post-limbal, and when I see that the graft is opened, this is real time, no editing. Normally it takes between 1 to 3 minutes time in 80 to 90% of the cases, in routine cases. So you just tap it. I don't put any suture, but initial cases, you should put a suture in the main wound, otherwise donor may come out. When you give air, then you can see your S is there. So you give more tamponade and you check that your S is right or not. Close the completely sutureless procedure. People often ask me DSEK or DMEC, which is preferred? Of course, the answer is DMEC. Because the anatomically DSEK is not perfect, so also visually. So patient will get 6 only few % of cases. Whereas DMEC, it is, you see 1 day post of such a thicker cornea is back to almost normal. So higher chances of 20/20 vision. So edil mange more. So, but the disadvantage is we know that it is very difficult and steep learning curve. Tissue damage is high initially, and there is high donor detachment. Long-term data is now we are getting, and it is going at part. We have published our result in different journals, and probably in different case scenario, we have also published our results. Endothelial cell loss is at par with your international results, probably better in our series because we take the higher endothelial cell count. And this is my batchmate, MBBS batchmate. You see the right eye, I did DMEC triple, and the left eye, she is having FECD. This is also doctor, my neighbor, just close to my house. This is again going good for a few years. I have also done little work on peripheral DMEC because that is the only area we can use peripherally trephinated donor for DMEC. We cannot do for DSEK or PK cases. And we have published our result in Cornea Journal, and we have compared the results with conventional DMEC with DMEC PD or peripherally trephinated donor tissue. And there we have shown that it is better in terms of endothelial cell density in peripherally trephinated donor. And the results are going good. Last year, we also compared the overall data, and also and that paper got the best paper award in American Academy. If you see this patient has 2 eyes, operated, one eye is DMEC PD, almost same 6 months gap, and another eye is DMEC CD. You see the cell count, this is after almost 4 years, it is 2,400, whereas this eye has 950 only. So donor ECD not much different between 2 eyes, and donor age is not much difference. So after experience of so many DMEC, do you still do DSEK in any case? The answer is yes. Typical indication for DSEK nowadays, aphakia with large people, aniridia, post-VR surgery with bad people, shade, ophthalmos, one-eyed with poor anterior chamber anatomy or extremely poor visibility. If you see the last 5 years figure, this is my figure only. I have done around 1300 EK, and you see that DSEK is gradually reducing, whereas DMEC is, these 2 years are pandemic year, but roughly I do around 250 DMEC and around 50 DSEK yearly. These are now for typical DSEK indication like this bat, PBK with overhanging bleb, with simultaneous bleb repair and This is my teacher. So I did this. These are extreme Fuchs dystrophy with cataract. Then what next? That is the minimally invasive procedure or injection of cultured endothelial cells. I do not have any experience, but Kinoshita, my friend, used to publish this paper in ROCK inhibitor. So we are discussing before the meeting. And he said that they have published in New England Medical Journal. They have a series of 11 cases over a period of 2 years. They are doing good. But the follow-up study is still not available. We have to wait there and from other places. Lastly, FECD, can we go without endothelial keratoplasty? There are two terminology for the same procedure, DOAC or DSO, Descemet sotorexis without endothelial keratoplasty, or Descemet stripping only. And there are plenty of papers available since 2016, and people are working it. Many people do not believe in it. Many people just believe in it with or without ROCK inhibitor. It works in some of the patients. So there are certain criteria of DOAC and DSO, like central Fuchs with central edema, normal or near normal periphery with good morphology, intolerable glera, it may be phakic. Otherwise, a good candidate for DMAC. So I did first DOAC in 2017. This is the other eye. I did DMAC triple. Then the left eye, the pseudophakic, I did DOAC only after explaining everything. This is first DOAC, first post up there. You see that the corneal edema is there. But this is after 1 month, 6-12 vision. And if some endothelial cell has migrating in the central part, this is after 3 months, you see that endothelial cells is same and the patient is having 6-6 vision. And second DOAC is a classical example. You see that this is again central Fuchs with PBK. This is phakic central Fuchs. So similarly, I did DMAC in right eye and I did phaco with DOAC in the left eye. So I'll go with the left eye, day 1, day 7, month 1, month 2, month 6, 9 months. You see the cornea is getting clearer. And this is the typical case where you see that 10 central edema is there. So if you see that after, this is the right eye, you see that this is DMAC done. And this is DOAC with phaco. And this is no PI in this. This is 1 year. But I was very euphoric. So I go for 3, 4, and 5 cases. Then I start say, if you see the ASOCT, if you see the central part, there is a definite gap in the central gap. You see that Descemet monolayer has migration has happened. So, and I used this drop, ripasudil drops. So till last to last year, 3 were going good, but this year I am telling is just 1 patient is doing good. 3 patients I did DMAC and 1 patient has gone lost to follow up. So this is only for probably for a temporary 2-3 years, you can delay the DMAC procedure, but patient will eat your head whenever for next 3-4 months. But DMAC you do 7 days, 14 days, the patient will be able to see very good. So the endothelial dysfunction, the possibility will be the patient presents with early stage drug therapy, culture cell and injections, or DOAC. And if the patient presents with late stage, you have to go for highly invasive like DSEK or DSAK, ultra thin, nano thin, DSAK, DMAC, or extreme cases you have to do PK. But I want to share you the last slide. This is close to my heart again. So when we considered about any keratoplasty, I see 3 circles. One small, one is medium, one is larger circle. So small circle is surgery. It is just like a marriage, just a happening. Keratoplasty is otherwise relatively easy. Anybody practice, you can do it. Any surgery, it is not a difficult thing. But second one, case or partner selection. This has a bigger role. Definitely, you have to choose a very good case to have very good long-term effect. But lastly, the keeping the honeymooning period longer is the biggest challenge. That is the follow-up. So unless you follow up your patients, the patient will not go good. And this what I called is you have to think for long-term success, not an immediate success. Thank you very much for your patience hearing.
Thank you so much, Dr. Samar. It was a fantastic and wonderful journey that you have undertaken right from the time when you started learning PK to you learned EK yourself, and you have done so many cases. And in fact, your initial cases were they were very successful. So you had the being a wonderful surgeon, and you did a lot of wet lab practice. So what would be your suggestions to us, the rest of us who are not so good as you, to how to,
No.
start
The
practice?
only thing that you need, what I understood, that you need a very good eye bank support to go
Okay.
forward. So when you get eye bank, so you do not have fear that whatever is going, if something is wrong, let it be like that. But you have a backup tissue. So
Okay.
use that backup tissue. So that is the main focus of learning. Wet lab, you have to go with it. Nowadays, wet lab is very difficult because human cornea is very difficult to get. Again, back to our fellows now, they are using with the goat's cornea. Goat's whole eyeball and goat's cornea because it is easily available in the market. So 5 rupees, 10 rupees, they take one eyeball. So I will say go with 10 dissection today. 15 dissection today. So it is like that they are going. So unless they do 50 dissection, I will not allow them to use in human cornea. Because human cornea, even the practice tissue is now precious. And you are not enough practice tissue because of this pandemic in this era. But when you have enough practice tissue, so you have to go practice, make you, perfect. Then when you get that courage of doing in a human being, go forward and do it. But again, you have to write selection of the case. That is, I did mistake initially. Right knowledge, now knowledge is everywhere. You go to the YouTube, you see plenty of knowledge, and then you do with your backup tissue. So if something is going wrong, convert to dissect. Demec, one go, not possible, okay. One tissue only waste. Do dissect. That way you can go for it. But again, club, that's what I was just discussing with, should be that you have to club your cases together so that you should not do the same mistake again, say after 3 months. You could rectify the mistake within a week. So you gather your cases, try to get the donor tissue in those days and space it, maybe 1 day 3 cases, 1 day 2 cases. So that is the way, probably I have learned in that way, because our iBank support is the maximum support I have got from.
Dr. Samar, it was very illuminating. I don't understand much of cornea, but what I understood was that as a person, the message which should go to all the viewers, that despite having been out of actual ophthalmology practice for the initial 5 years, you came back, followed your dream, which shows very clearly that a person who is sincere, who is passionate, and is focused on what you are doing and honest with everything can achieve great wonders. And not only that, your last slide shows that you are even romantic. So I really hats off to you, and I would not ask any cornea related questions, but I would give that honor to all the panelists and Uma. But it was very, very impressive, and very moving. Thank you.
Thank you.
Any panelist has any question?
Basak, how do you choose the size of the graft? Is it same for normal cornea, large cornea, or small
No,
cornea?
I give 1 millimeter on either side. So I check the horizontal diameter of the cornea. Then we should have 1 millimeter working zone. So it should be, your graft size should be 112 millimeter less than the horizontal. So
But what
2.5 millimeter less than your horizontal diameter of the recipient cornea.
and what
By
about
and large, 8 millimeter is the standard size in our part of, because we have a smaller corneal diameter, maybe 0.5 millimeter more smaller.
okay? But some people they are using 9.5 millimeter or larger size. So
Or DMEC or DSEC.
but for DSEC,
For DSEC,
so
9.5 millimeter, I don't
nine.
know. It is except in 9.5, it is except very high myope or megalocornea, you can use it. But usually 8.5 you can go, but 9.5 you do not have working space. So you have to play with the side ports. So you have a main
Okay.
port and two side ports, but you have to play
But-
with the BSS and water from the side ports. So
But
if you
they-
put a 9.5 millimeter, you have closed your side ports.
Okay, but they say that you have populated more endothelial cells.
No, a lot of publications are there. They said that 8 millimeter, 8.5 millimeter, they have similar result because Western people have a larger diameter cornea. Initial thought was 8.5 millimeter is doing good. You think about PK also. PK normal, what is the normal? 7.5 is the
millimeters.
standard.
Yeah.
Standard. So why not we are doing 8.5? Because we know vascularization, we will approach towards the limbus. Similarly here, the population, a lot of PK are going for 20, 25 years. Nothing is happening. So that is actually 8 millimeter is the standard average for all practical purpose, ideal size.
Okay, so what about the incision, main incision? Are you giving clear corneal incision
No,
or
I am always scleral tunnel.
scleral tunnel? Okay.
I am from the superior side. I am operating. I am not from temporal approach because of my some physical problem. I cannot operate from temporal. One or two case, but long standing. I always, even my cataract are from superior side.
And what about the after cutting with microkeratome, your graft you are using immediately or you take some time so that there is thinning of the graft?
Normally, I do not use microkeratome, but when I used to do it earlier, immediately, no time. I mean, those are actually, if you give adequate thawing time before pass through microkeratome, there is no need of waiting. But if you are taking a pre-cut tissue from elsewhere, it was in the refrigerator. Now, when you will be using it, then you have to thaw the tissue for about 45 minutes to 1 hour. So that tissue get right thickness. Your adhesion will be tamponade and adhesion will be perfect.
Do you use ultra thin DSEC also?
No. I have never used. I am a manual master. I am very comfortable with manual, and there is no difference between. I have shown the picture. I have plenty of pictures, and there is no difference except the easiness. There is no difference. Manual is exciting actually.
Okay.
Uma, so can we go on to the next talk in case we have additional
Dr. Rohit,
questions?
thank you so much, Dr. Samar. This was fantastic, and it's a great honor to hear you.
Thank you.
And
So
best of luck for your election as President AIOS.
Okay, thank you very much.
Yeah, he is standing
Sir,
for president, so I think.
we all should
All
support.
the best, all the best, Dr. Basant.
Thank you.
So with that wonderful talk, and I said we labeled this session as a generous session because we are moving from in a time machine from past to the present. We have another inspirational person, Professor Rohit Shetty, who has really transformed the research paradigm in this country. Professor Rohit Shetty is the vice chairman of Narayan Nethralaya. He is a clinician and translational scientist at the Grow Lab and is faculty Department of Ophthalmology at the Maastricht University in Netherlands. Professor Rohit is a cornea and refractive surgeon. He did his residency in ophthalmology from St. John's Medical College, followed by FRCS Glasgow, and then did his PhD from Maastricht University in Netherlands. He is he's a great teacher, a great researcher, and when you talk to him, you understand his focus, his passion, and his sincerity. He's a no-nonsense person, and when I first met him, I was extremely impressed by the details to which he went through with everything he talked about, every project he had taken, the way Narayan Nethralaya has transformed under his leadership. There are people flocking to Narayan Nethralaya for the Cornea Fellowship and other fellowships only because of one man, and that is Professor Rohit Shetty. He has achieved numerous laurels, has over 260 publications. He got the Achievement Award from the American Academy of Ophthalmology, the best cornea paper of All India Ophthalmic Society, the Colonel Rangachari Medal from All India Ophthalmic Society, the IGA Gold Award for the best paper on decision-making nomogram from intrastromal corneal ring segments in keratoconus, and also the Case Beer Award at ISRS 2019. We welcome Professor Rohit Shetty. He has been a guide to numerous fellows, but more than that, there's a wonderful PhD program which is there between Narayan Nethralaya and Maastricht University, and a lot of people are undergoing. In fact, at one stage, I also thought of telling him that I would like to do a PhD program because it's really inspirational to be involved in the translational research which Professor Rohit Shetty is doing. Welcome, sir. It's an honor of Noida Ophthalmic Society to have you. Over to you for your presentation on the future of corneal refractive surgery. Thank you.
Thank you, sir. And thank the Noida Ophthalmic Society, the panelists, Samar sir, always honored to speak after you. And the journey was wonderful. And it was a nice mix of passion, hard work, and dedication, what you showed. I think each one of us should learn from this. Dr. Uma Madam, thanks for moderating, and I will share my screen now. Can you see my screen?
Yes, sir, we can see.
Yes. My talk today is on AI simulation, prediction, and imaging, the future of refractive surgery. And these are my financial interests. I do receive grants from government and other companies for a lot of my work today. When we look at innovation, the only thing which has remained constant is the power of change. And Dr. Samar sir, Basak sir mentioned beautifully about his change from way back in 1990s to today. Whether it's ophthalmology or whether it's refractive surgery, it's all the same. There has to be somebody crazy enough to take this dream, what you call a crazy dream, and you have to start trying to make it out. So this has always been my philosophy, is that everything seems crazy until you do it. If the whole world looks at you as crazy, you make a presentation of gene therapy 15 years back. Everybody thought that this will never work. This will never come to practice. But today, including our hospital, we are all at the last leg of taking this from a clinical, non-clinical to clinical studies. So let's start with a few examples of the modern day. What I'm just showing is not something which is just used as a research tool. All what I'm going to show today is what is used in my clinic. Look at keratoconus. Some are stable, some are progressing, and we really don't know who progresses and who is stable. One of my first talk today is about AI in refractive surgery. Way back in 2010, we decided that we should have our own AI department in our research unit. And we built a good team of 5 to 6 good engineers, and we started working on it. At present, one of my ex-fellows, now a consultant, Dr. Kairek, is doing his PhD in AI in refractive surgery. And a lot of my work is from his PhD dissertation. So this is our journey at this point of time. I'm just concentrating now only on the refractive surgery, but AI, we are trying to bring it into glaucoma, retina, a lot of other areas. AI in keratoconus. What is artificial intelligence? We have heard about this. It's about looking at parameter other than the obvious. Our brain is tuned to look at obvious parameters. It looks at things which, at this point of time, it's not possible to look at multiple classification and plan it, because we look at, as clinicians, we look at what is obvious based on our experience, based on our past history, and then we take it forward. And that's a machine learning and a deep learning, which once the machine starts learning itself, it uses data points from multiple sources and inputs it into what you feel should be the real picture. So we already have some basic AI build platform. I would call very basic. They're not truly AI, and they're all for, but ultimately we need to have multiple parameters like this. And how do you all add up and make a decision? This is where it comes AI and keratoconus. Making a right decision, which one will to progress, which one to wait, when you cross-link. So first research question is, can AI just help in prediction the progression? It was extremely elaborate study. Took close to 2.5 to 3 years to get the scans. And every scan had to go to the raw data of the scan, not just the images like what we get here. Raw data is very important, because if the scans were not taken properly, the AI will start reading it wrong. It's very important, especially in retina also, if the machine is not giving a good images, and if you're teaching the machine to read a wrong image, the output will also be garbage. So garbage in, garbage out is a concept which we have to keep in mind. So we looked at all these data points, and then the machine came out with its own classification of what it would consider as a progression, and it was picking up in close to 85% of the time. Very interestingly here, for all the people who believe in Pentacam, including myself, the bad D and other things did not fare in it. That means we as clinicians would look at a bad D and decide, or some of the parameters, but the AI was not looking at it. This is very, very important point. AI ignored that and looked at other things, which probably we would not look at it. And this was a paper in JRS last year about this. This is one of the world's first paper on AI in progresses of keratoconus, and this became one of the one of the very highly cited and very widely read papers in 2021, which looks at AI to predict. So we started moving forward. We thought, why not just look at only the corneal topography? Let's look at the epithelium and below the epithelium, because corneal surface topography is affected by ocular surface. So we started looking at machines, we started looking at the Bowman's layer. And this Bowman's layer is what we should be measuring, because this layer of the epithelium can be directly be affected with multiple things. So we started mapping the AI. Now we use the AI on the epithelial surface, and MS39 is a very nice OCT, which looks at with the epithelium elevation, and this is without the epithelium. This means that, of course, this is the one without the epithelium, what the elevation is. That means it virtually subtracts the epithelium and just gives you the Bowman's. This is actually the Bowman's layer elevation. This is a very important thing, and this values, we started looking at it. And again, we were able to predict a completely different indices out of this. And this paper is now in the last leg of review at the GCRS. Then comes demographics. Demographics is very important because we always look at what is the high risk factor for keratoconus progression. And we found that this is a paper in IJO many years back. We looked at the risk progression of thing, and based on the risk progression, we decide what to do. It is very important because this is a high risk scoring for the keratoconus patients. And we looked at IgE, eye rubbing, and various factors. We also looked at serum vitamin D. All this were used from database from many years of work which we have done. What we did was we tried to identify and analyze what were the demographic factors. This is important. We know about the topographics. We know that we need to know, and we looked at the high risk factors. And what we did again here was we used these factors and figured out what was the one which was predicting the patients to go for progression. And one of the most important factors was IgE. And that was, I would not expect, because of the high variability of demographics in keratoconus, we could not expect this to go beyond 70 to 75%, but it was still well within the thing, and it was able to predict a good number of people who are stable, because those patients did not have these changes. So the most important thing was the gain of information. And this is the matrix which we follow, the random forest, scoring, the multiple AI metrics. And this is all built in-house. We do not depend on any other software or any other companies for this. This is one thing which I'm proud of because it's built, and my own PhD and now a consultant, Dr. Kairek himself does all this AI. So that means it's not so complicated as we are all told that it's very complicated. It has to be done by a certain set of people. What I am demystified this is anybody can do it, and you can actually give, and you can use it in your practice as you move on. And we figured out that these were the high risk factors, what is necessary for it to progress. And this is again a very important find, and we are just writing this as a paper. Sharon and me worked on ocular pain and the different types of pain, ocular pain and ocular surface disease. And there was no uniform algorithmic approach to the management. So this is something which we looked at, and this is work by Sharon. We created an AI model to classify ocular pain based on multiple factors. And one of the major issues we see in ocular pain is all these are dendritic cells on the cornea, subepithelial nerve plexus, that region that's below the bombers, you see a lot of these dendritic cells. And Sharon classified it as discordance score, signs and discordance, discomfort and concordance grouping. And this used an AI model to classify the pain, people with pain with different etiologies. So basically, and this again is beautifully correlated well, and they use the confusion matrix for random forest. Is again a type of AI, and it tells you what are the major features which makes the patients to develop pain. So basically, when we look at the AI, it's virtually can be used in every practice, in every area of your practice. I've just used it refractive here, but we're using it for cataract, and we're building our own database. We build it and then use the AI, and the ability to predict is phenomenal. We also wanted to ask a simple question: what makes a patient decide a particular surgery, and and when does a patient decide not to go for a surgery? And again, we took the data of all the patients who underwent surgeries. These were the numbers. This was what he underwent and what was advised, occupation, the address of where he came from, education, and including a source of referral and also gross salary, which was calculated. We thought that whether it's a salary which drives them or something else, and we played an AI. And most important thing was it was just not the money. It's about time spent in the clinic. source of reference. That means if it's sourced from a person who's already undergone surgery, role of insurance is very, very important. Younger age group were the ones who were ready for it. And the accuracy was pretty good on this thing. So what it means that we are in a very, very good place about using AI, even in our clinic, to pick up what makes them to come to you. Probably I never would have thought about this. You spend less than 1.5 hours. That means that's a good time. If you spend more than 3 hours, they would not want to do it. Occupation, of course, we understand. Source of referral was also important, younger the age group. So all this will help us to really look at how do you do your counseling better. And like I said, the journey of AI has just begun. I just showed you very few examples of what we are doing in the practice. Beyond move to the simulation, these were all the topographies and, biomechanics, people know about the CBI, PBI, all this is from the biomechanics, this is from a topography plus biomechanics, and this comes from your topography itself. These are all indices, what we have, and sometimes it's confusing. Sometimes one is normal, these two are normal, these two are abnormal. Sometimes this is abnormal and this is normal. And sometimes this is normal, this is abnormal. And see, this is extremely difficult for a human being to decide what do we do, because none of them follow a pattern. So why in these cases, we went back and look at a simulation model. Again, we built a small team of scientists who work in fields like who have worked in simulation. When simulation is what happens when there's an accident, what happens when the plane, the pressures, the airflow of pressures, everything. How does the plane withstand all this? So we wanted to bring the same concept into ophthalmology, and that's what is a simulation model is. You need a topography like a pentagram, you need a biomechanics, and with multiple mathematical driven, the cornea is divided like a mesh here. And it becomes, cornea is no longer a static tissue, it becomes a dynamic tissue, because you're taken the cornea, divided into a corneal mesh, and then you can use any kind of pressure force to see how it works. This is exactly something similar to what happens here. The whole car is like a mesh, the plane is like a mesh, so that you can build in pressures accordingly. And we created the same thing on the corneal surface. We published this work where we created a simulation model, pre-LASIK and post-LASIK, and we created a simulation. The dotted lines are all the simulation. You can see that all the dotted line matches with what happens post-surgery. And this is a classic example. That means that every time you do a surgery, you exactly matched what happens to it. It means that you are predicting exactly what you want even before you've done the surgery. This is how much the cornea gets weaker. For the non-cornea people out here, simulation measure, because everything in refractive surgery is how much it's becoming weaker, or you do some procedure, how much it become stronger. So if you can predict that, you have a great tool in your hands. And this is what this whole and this AccuSim, or the Pathfinder, we call it, helps in predicting everything. And this is completely made in-house, including the software. It took close to 8 years for us to come to this stage to get this screen. You can do the procedures, you can write all the data out here, and you have to run it. This uses AI and a simulation model. Simulation and AI are not the same. AI gets to you, it understands what is happening, and simulation gives you the prediction. And this is a report what you get. If I want to do for this patient a PRK, it will tell me that the predicted post-op is on a riskier side. That means if it's on this bell curve, it's safer. It's away from the bell curve, it's not safer. It will also tell you how much weakness the cornea is going to be. So it gives you a warning, which is very, very important for me to decide what type of a surgery I should plan. Let's look at this patient, 22-year-old female, -5, 5.5, 6 diopters. The biomechanics indices are all again confusing. Bad D is suspicious. This is suspicious. This is suspicious. This is borderline. So what do we do with them? So when you do on this patient, I can simulate it for LASIK here. And when I do a simulation of LASIK, it tells me that it is already on a borderline. And it says that there's a moderate risk of ectasia. And it even tells you how much the cornea is actually getting weaker by. And it even tells you based on your IOP, it's based on intraocular pressure also, and post-operative what really happens. So it gives you virtually every single thing which it predicts. Now, you don't want to do it because you know that there is a risk out here. So what do? PRK, again, it is not as much, but it's still on a riskier side. It says low risk, and the other side says a moderate risk. So what we do, in these cases, what we do is when we do a smile, and you can probably do a smile extra because you strengthen the cornea more. You can do a PRK also, but in these patients, you can choose the procedure, either smile extra or a PRK extra, because it was a higher refractive error. So I chose to do a smile extra. So what happens is you can choose the procedure, or you can do an ICL, but I think this patient's ACD was not good. So these patients otherwise would have definitely gone in for an ICL. And again, same kind of thing. You know that there's a biomechanically weakened, there's a skiving of axis, which is not good. Again, you do it and you know that there is a chance, and it tells you there's a moderate sign of ectasia based on the simulation model, based on how the cornea is getting weaker. One of the happy moments is that this is used in many, many places across the world today. And this is our contribution. More than 20 centers in Australia, New Zealand, Brazil, many centers in US. We just got a patent, and now this will be one of the things which will be probably used in your Pentacam. When you see this AccuSim, it will probably in future tell you, and you will give a printout about this. When we look at the future, one of the areas of interest has been looking at the collagen. And collagen imaging has been one of my favorite areas of work. And this is how a collagen is. You can see that these are a strong collagen, and these are the peripheral fibers, anchoring fibers out there. The darker blues are healthy, and the lighter blues are not so strong, and peripheral red fibers are the anchoring fibers. So every single patient, when you have a suspect here, when your corneal biomechanics is weak, you can see that the central fibers is good, but these areas, the collagen is weak. And in this case, even though the corneal thickness seems okay, look at this. Only the central small area of collagen is good. And here, there's a complete loss of collagen fibers, which means that the collagen is extremely weak. And these kind of eyes would probably end up in having a problem or having more changes. And again, using this thing, we can probably, in this case, probably an ICL would be better, because look at just the difference. The collagen orientation is completely different. So this OCT again was built in our lab, and we want to commercialize it later sometime. This was a patient who had a smile, referred to me complaining of glare. And you can see there's some amount of decentration. But what was interesting here is decentration here. But look at this area is like small amount of bulging. So when we did this PSOCT, we figured out that he may be developing an early ectasia without very, very early ectasia, which amounts to loss of this collagen changes. And you can see that this area, again, you can see those whole changes out here. So this again helps us very much, and many companies are keen to use this into practice. How do we know what we are seeing is the real truth? What we started doing is, the same patient, when we undergo a PRK or smile, we started collecting the epithelium or the lenticules. We call it the PSOCT, clinical and molecular data. And we started looking at whether it's telling the truth. So when you have a low amount of this images, it means that the collagen and lysyl oxidase, which holds the cornea, is also low, which means that both this machine was exactly telling you what a molecular data is showing, which otherwise it's impossible to do on a living eye. What are the futures? These are all the factors which comes to our clinics, all driven by molecules, and each molecule has its own unique molecules out here which drives them. And I don't want to get into all these molecules, but they are the culprits. So these things need a specific antibodies to block them, and we need to find them before we block. We have different kits, but what we designed is something which is very unique. We've been talking about it for some time, but this is something which we got into clinics now. It took us around 8.5 years of work. So any innovation, a good one, would take a decade. So when we talk about it, we are sometimes we are very restless. We think, oh, it's not come. You've been talking about it for a few years. Anything which comes early also disappears fast. So this took 8.5 years for us to do, and this is now used in the clinic, and you can detect everything. What is interesting for Dr. Ajay sir and many of them, your VEGF and ICAM1, both responsible for your non-responders to anti-VEGFs, and your IL-17, they can all be detected from the tears. So it is a very, very beautiful system. This is called a lab on chip, 30 minutes in your clinic. And what it does is, there was a small video, I don't know, I can play it a little later if anybody wants, that we put all the tears taken from your Sherma strip, or we have a dilution methods. You put it in, and this is put inside here, and this runs the analysis. This is used in cancer. We uses this microfluidic design, and in 30 minutes you get a report about what are the various things which is affecting. And these are all major ones, and more can be added. For presently, we are using it both for the retina. These are the two important things for the retina. This is for your dry eye panel and MMPs. And in future, we're trying to get the locks. And TNF-alpha, very important one, especially when you're looking at glaucoma, fibrosis, or you're looking at even scarring after PRK. It's probably one of the most important things. How does it help? Virtually, you can titrate your treatment. And this is exactly what a report will look at. It will tell you the normative database, and it will tell you and what is high and what is low. For your retina, VEGF A and B, both we can look at. And and you can titrate it. Tomorrow, Liftigras comes. Liftigras costs 3,000 to 4,000 per bottle. How do I know that I should give it or not? If your patient has a high ICAM1, Liftigras, should I give a restasis? If you have an IL-6, give a restasis. Should I give a Trehalose drops, IL-8, IL and MMP9? If it's IL-17, what works? Doxycycline works. Or you give a IPL or VEGF-A, what works? Maybe give a vector pulsation. This is the future of how an AI and all these things can really help into your practice. So what is a holistic way of doing it? The holistic way of doing it is to mix everything. I'm sure this will happen, but it will take another 10 years. Like I said, I'm extremely optimistic and patient when I'm doing any research, because I keep reminding myself anything which happens very fast does not stand the test of time. So imaging, demographics, molecular markers, predictive marking, everything gets into a model, big data, and the machine itself will start analyzing. And what I just showed is a few examples of this. And that's the power of all this. And now at this point of time, we have few of them in here. Maybe in 10 years down the lane, we would probably include more of it, and all that will be integrated into your softwares. So AI is a very important tool. We can use it in multiple areas. Prediction and simulation are also part of refractive surgery or cataract. There's a huge untapped area of polarization sensitivities. I've just shown the cornea. There's a beautiful images of retinas also, and my retina colleagues are working on it. And the way to go is to integrate a holistic approach. And like I just showed a clinical example of lab on chips. I'm fortunate enough to work with one of the bright scientists. We have 47 of them with 10 engineers who work on different zones. We have divided them into different groups. Some work on ocular immunology, some work on molecular signaling, gene therapy, some work just on AI, simulation, and it's very happy. And what I feel is the future is going to be on eye gaps, where you drive the inflammation genes and proteomics into surgery. It may sound very futuristic, but the future is so fast that without giving us proper time, that future is just in front of you, and just time flies. I thank the society again for this opportunity, and I'll be happy to take any questions from the audience. Thank you.
Thank you, Rohit sir. I think all of us were almost on the edge of our seat. It's actually an amazing display of what the future probably beholds for us. I would call it three P's. You know, it's like everything has become so precise, so predictive, and so perfect with all the molecules, all the AI mammograms which you have put in place. And I am personally overawed by, no, it's fabulous, really. Thank you again, and I would leave it to my Cornea colleagues to. But for me personally, it's a great learning, just to show that all of us must catch up fast on AI because it's virtually knocking on the
Query,
can I ask?
Surabhi, you had something to say? Sorry.
Ma'am, I had a query. Can I ask, sir?
Yeah, please.
Yes, please.
Sir, in case of patients who have Shermas around 3, 4, and 5, anything between my, severe to moderate, let's say even 6, 7, I don't know how to decide whether you need to give cyclosporin, chloroquine. What are the things which tell you what would help? Because when I try chloroquine, patients say it burns, stinging sensation, and cyclosporin also the same. You have to wait for 3 months at least to see the response. How do you decide in which patients in this category which one would work? If you just have these factors.
Yeah. Like you rightly said, Dr. Surabhi, one of the challenges, this is, I said, everything what we discover is because there is a need. They say discovery is the mother of all inventions, the need is the mother of all inventions. So what happens is each and every molecule has a specific function, and that we don't know, because for us itching is the same, but itching is driven by close to 15 molecules which we know and other 100 which we don't know. So when you have a molecule which itches, for example, if it's IL-17A, is a molecule which is driving this person. You give him cyclosporin. Cyclosporin doesn't work on IL-17. It's like antibiotic. If you have a gram negative, you're pumping with a gram positive drug. He may improve by 10%, but not more than that. Exactly the same concept works today in our molecular dry eye or anywhere. You're pumping them, assuming that something will work. Or if it's an ICAM-1, it is not going to be treated by your cyclosporins or anything. Even steroids doesn't block it. So that's where when you actually, it is very difficult to put an algorithm for that. So when you have kits like this, when you do the tiers, one shot you get a report of all the 10, 15 culprits who are high and low. Based on that, you decide. For example, in next year, you'll have the leftigrast from Zedra. So if the patient has huge amount of ICAM-1, so all you have to do is forget about cyclosporin, forget about your chloroquine. You just start him on a leftigrast, you're done. And we want to make this kit as low as 1,000 rupees, 1,500 rupees, and the machine should be as low as around 7-8 lakhs, so that everybody can use it. So the challenge now is we don't have a real answer for your question because we are shooting in the dark. And for example, the same thing applied to Ajay sir's thing. There are 15-20%, I don't know, plus or minus, are non-responders to your treatment because your VEGFs don't act on those things at all. You don't have a ICAM-1 blocking agent today, except for steroid. But a lot of them don't use steroid. So how do you know that whether I should give an intravitreal injection of steroid, Eylea, or one of them, if you don't know what it is? So including, we are trying to bring a dopamine kit. Dopamine predicts myopia. If you have a higher dopamine, you have chance of having myopia controlled is better. That means there are different ways to increase dopamine. One is sunlight. That's sunlight have a more.
Sir, is there any kind of blood test which is sort of
Not
helpful?
really. So when you have extremely confusing thing, what really works for me now is combination of iLight or one of the IPL and LipiFlow, because all of them just washes away those inflammatory markers. I don't know which one, but it works. It's like it's not actually a targeted therapy. It's like a carpet bombing. But at this point of time, that's which is working.
So you are saying that IPL would work in such cases?
Absolutely. We just got a paper published with all these molecules, and IPL did work very well in cornea. Just got accepted yesterday.
And another thing I think which is important is to understand how much our tears reveal the mysteries of the eye.
It does reveal a lot. We have just,
Yeah.
I think we must have just touched 0.0001% of the mystery. I think the big 99% or 99% more is not even touched.
So with your presentation, do you think that with all that high-tech thing coming in, will it flow down to a common ophthalmologist in future? Or because
Yes.
by listening to it, initially the word is, you'll say, I'm flabbergasted by it.
There's our first 10 years goes in discovering it, and the next 5 years goes on bringing it to everybody. So we finished the 10 years Hayat, the incubation time. Now my entire goal is to make that kit, the box which does the reading. It's used in cancer. It is not discovered by us. That whole kit is used in cancer for the same reason. This is the first time we brought in tears. So we want to bring it to less than 10 lakhs, 7-8 lakhs. So everybody can keep it. And the kit, the cost of the test should be less than 2,000. So that's a challenge. That if you're able to achieve it, then anybody can use it in your clinic. And you don't need a lab person. My fellows do it. And by half an hour, we get the result.
So are you using this, Dr. Rohit, routinely in your clinic?
Every day, ma'am. Every day. Every day for the last 1 year.
Okay. So how many tests do you do in a day or on an average?
The kit can do up to 32 tests a day.
Okay.
And
And
I
so-
can do it any number.
Management is tailored accordingly.
Yes, ma'am.
So at present, the kit which we have of MMP9, how specific or sensitive is it?
It's a good one, but the limit of cutoff is 42, I think, 42 nanograms per microliter. But MMP9 patients start having problem when you are at least 15 or 20. So 42 is really high up as a bar. They should have kept it at least 20 so that you would have had more patients being positive. But MMP9, if you rub and do the test, you will still be positive. So what we have done is we use MMP9 and we also use around 7 or 8 of other things in the thing. And all the things what I just said is not only in our hospital, it's used. The kit, the simulation software is used in 40 countries across the world now. And PSOCT is a challenge because we had to make that. Every part was handmade. But I think 1 or 2 companies are keen on it. So maybe in 2-3 years, they can. It's just that system of hardware has to change. So hopefully somebody will come out with.
Sorry. So the PSOCT, you said that there's a light blue, that a dark blue, and then the red. What do the red and the orange?
Those are the red ones are the anchoring fibers. If you go back to the textbook diagram of even Samar Basak's book also shows, in the basic book, what is written in the peripheral fibers are different. The central fibers are more condensed. So what happens is the darker the blue, it means that cornea is very tighter. Peripheral fibers are oriented different. That's why you get the red. This is exactly the classical picture what you see in a textbook. So when you use that along with your topography, you know exactly what the cornea is behaving.
Any comments by Dr. Samar, Dr. Goel before we move on to?
It's excellent. I mean, I'm a fan of Rohit Shetty, and he is.
All of us are.
Yeah, he's just crazy. What he is, he is giving what future is like AI and simulation. Even all sector of medicine, it will come. Like
No, it
not only in
also is.
ophthalmology, but in all sectors of maybe down the line 15, 20 years, the total, I mean, most of the centers, especially the private corporate sector, they will bring all the machines. And initial
And
cost will be higher. And you know, as the FECO machine initially was very high cost, now the individuals are bringing in their clinic. So similar thing will happen after 15 years.
so
It is
one thing I
future.
wanted to tell you, sir, is that when you talk about AI, we get really scared about who's going to do it. All that AI work I just showed, the first half of it was done by by an ophthalmologist who had no idea of AI a year back. So that means anybody can learn it. It's just a fear and myth that, this is something different. And once you know the trick of it, you can build AI on anything. Now I tell him, I want an AI on how many patients did not come, how many patients. He just takes the data and makes an AI within 2 days. So AI is not as scary as we think. I want all clinicians to understand this. Do not worry that if AI, I had to use a separate Google Giggle. It's just not, it's just the scare which is making us to dry away. If you sit with the right people for 2 days, you will build your AI in your clinic.
Right. We are also doing it on different
So,
patients.
so I think, sir, we have had one earlier session with Dr. Rajiv Raman from SM where he spoke on AI. And we want to make the Noida Film Society and all those people who are logging in more aware of AI. And that's why I was really looking forward to your talk. Thank you so much, sir. Please stay with us. We want for the second session. I would have preferred to play a small video from our sponsors, Avesta, but for paucity of time, we will play it in the end. I thank the Avesta team led by Mr. Dhamija, who has been very warm to us, and thank you very much, Avesta, for sponsoring the session. We will show the video at the end of the meeting. I would request Uma to now moderate the case discussion. So I think since we are now having about 32 minutes from 9 o'clock, we'll probably extend it by another 10 minutes or so. We can have each case for about 7 to 8 minutes. Will that be okay for all the presenters? And then maybe 2-3 minutes for discussion. Okay, Uma, please.
I would invite Surbhi to present her case. And Surbhi is an extremely talented cornea surgeon working with Ajay also. And Surbhi, you can go ahead.
Yes, ma'am. Is it visible?
Yes.
Yep.
Thank you all. I'll just quickly go through it because of paucity of time.
Surbhi, can you please put it on the presentation mode?
Yes, sir. Yes, sir.
Yes.
Is it visible?
Yes.
Yeah. Thank you, everyone. I'll be taking a case of PBK. This is a 52-year-old female complaining of blurry vision for the last 2 years. Had gone for a cataract surgery 2 years back. Sadly, she was pushed around by most of the specialists saying that it's going to recover, it's going to recover. She came to our center, and the day of presentation, her vision was 660, which was not improving. Left eye was 6.9. IOP pressures was okay, all right. Left eye had early cataract. Right eye showed a hypertrophic epithelium in the nasal half of the cornea as well as inferior with the surrounding edema and folds. AC was quiet, pupil was round, PCR was in the back, no evidence of any vitreous strands in the AC. Fundus was within normal limit. This was what we planned. We planned for a DSEC. So she presented, we did, and this was the Paki map, which showed a 706 pre-op with the ASOCT showing a hypertrophied epithelium. This was a first day post-op. Unfortunately for me, temporal half was not attached well. Even the inferior temporal as well as the temporal, we had to take her up again, bubbled it, and thankfully by 7 days, her Paki had improved to 567, graft was well attached. And this is 2 weeks post-operative. She did well. Serially, vision improved from 2/60, 3/60 to 624. Final time, she came with 612, improving with a plus 1.5 at 10 to 6.9. This is a small video of the same case. I quickly take you through it. Debridement was done, and calipers, I took the sizing, and after that we took care of all the, I did a slight pressure, stab incisions for the side port, and inferior peripheral iodectomy was done, vitrectomy cutter, trypan blue staining, anterior marking to help in the scoring. So the scoring is very important. You have to be very careful, gentle. You can see there's some amount of folds coming. That was too much of pressure. Here I'm going a little bit more carefully, gently scoring it out. And then once I know that it's a slightly loose, I try to scrape it and pull it to the center. And once I'm done, I take it out in total, check for the whole thing. I see that it's all come out, but then again, I always play a little safe and do a slight scraping with the endo scraper, clean out all the viscoat, put in my sheet glide. I prefer to do a clear cornea. I put in a sheet glide. This is the cornea with the S mark seen, with a very smooth movement. This has to go in and that has to come out. For me, in this case, the graft did not go fully in, but I was careful. I had to first put my stitch, and that's what I did. I was careful that it was not taking into the edge of the graft. I put in an air bubble trying to get it to move, but it did not. I put in my 2 other stitches and then got it with the airtight wound, and also got the double ring sign. This was how we managed the case of PBK and put in the lens. So the advantages, we all know, suture complications are less, no alteration on the antecorneal surface, faster healing of the wound, quicker procedure, better outcomes, and reduced rejection chances. Indications, we all know, anything which has an endothelial dysfunction. What not to do and what is safe is for what I know from my cases. So we need to see pre-op, intra-op, as well as post-op. This is a very important Excel sheet which I found. It takes into consideration, especially for people who are just starting off, you can actually database your pre-operative, operative, see for your complications, check out, and it's very important to even see the other eye. This is also a part of the same article wherein they've told us about the importance of each and every parameter to be taken into consideration. Also see for the age of the patient, which seems very silly, but I feel it is important because you can plan for a triple, and also see for eyes cases, it has to be done irrespective of the age. You also see for the lens, you should go for a hydrophobic acrylic and also aim for a 1.5 myopia. So these are the short slides which I take you through what I have learned from my cases. The first step is always measure, take your time, diameter, and then judge, decide about your corneal graft size. I always subtract 2 mm from the total corneal diameter. I always mark the anterior surface of the same diameter so that it helps me to score and helps as a guide. Debridement depends upon your cases, it does not harm. Stab incisions, I feel, have helped me rather than doing the same horizontal, how we do for our phacos. I feel the short stab incisions keep the integrity of the AC very well. The wound, if you're going to be doing a scleral, you should take care of the bleeders. Very, very important. The AC. This is pointing wrongly. I feel this is going to hamper your scoring as well as placing your graft. It should not be pointing towards the pupil, but pointing towards the limbus. I prefer Helon, so I don't use too much of the this method. If you do, you have to consider iris prolapse as one of the complications which can happen in anyone's hands. You have to remove it, take another step, either wash it out, use Helon, air, anything, but avoid the iris from coming out, and also less tampering with the iris. Also the tunnel, when you're taking out the sheet glide, be very careful that your other hand instrument should be anterior to the anterior lip. Be very careful, otherwise the graft can also crumble and come out. Considering this, the first and the foremost thing is when you're using this, always when you're inserting the graft, switch it off or best to remove it completely, the AC maintainer. Lessons which I learned from all my cases till now, it's not too many. Good prior counseling, a detailed informed consent definitely helps you. Take time to do your groundwork as every case has its own set of challenges and points to be thought about. And ASOCT has to be done. When nothing works, because I've had a few cases where I've not resorted and I've done a couple of times bubbling, but finally venting incision really does help. Initial 10 to 15 cases, I feel simple PBK cases would be the way to go. Never be in a hurry, and when in doubt, always discuss with your peers and seniors. Summarize, you should take ideal cases would be PBKs, early fugues with cataract, visibility of the AC, at least rough idea about the AC, central pupil, no written the AC, and if there is a opening, it should be a small central yak cap. And I believe we all can go this way. We should share our experiences, we should learn from each other, we should not lose hope, and we should together gain experience and confidence. So happy patients make happy specialists. Thank you so much.
I would like Samar sir, the master himself, to give a few his feedback.
So this is very nice presentation by Shurbi.
Thank you, sir.
Only I want to say why the graft detachment happened in this case. To me, if you see and rewind your video, you will see that your cleaning of Hilon probably was not perfect before insertion of the graft. So there might be some amount of Hilon left behind. That is probably the reason. Otherwise, it is a very perfect surgery. And your air tamponade in this particular case is not perfectly okay. You can see when you finish, still there is a rim of fluid there along the limbus. That means you have to put little more air. Sometimes airs tend to come out from the side ports or main wound. That time what you will do, you will do a 30 gauge needle with a 2 cc syringe, long stromal tract in the 30 gauge needle, and in the left hand you take a bud and you just inject air, and when you come out you just place the bud on the needle tract. That way you will give perfect tamponade, and after 10 minutes or 15 minutes you just remove some of the air and replace by BSS. That is, otherwise it is a very perfect surgery.
Dr. Goyal sir, you wanted to say something?
So you're muted.
I don't use anterior chamber maintainer actually. Anterior chamber maintainer has been creating a lot of problem for me also. So initially I used to do with anterior chamber maintainer, but actually when you take out the anterior chamber maintainer also, it is not leak proof. So you have to put a suture also there in the anterior chamber maintainer, and it causes more of a problem rather than help. Because sometimes by mistake, if you have not removed the anterior chamber maintainer in time, then your graft might come out of the main incision also. Because by mistake, if you have just put it on, or your assistant has just put it on by mistake, so it will push the graft out. So secondly, do you have used air or SF6 for rebubbling?
I use air, sir.
You use air, but
Yes, sir.
actually what I prefer is SF6. That gives you much better
So
success
actually,
rate.
I had a patient where I had to do it 3, 4 times. She had, I don't know the reason. Sometimes I try to look back, see my cases, but I don't understand why I had to do it so many times. Finally, I had to use SF6. So at that point, it helped. But I
Yeah.
don't feel in the first 2 times you need to go into SF6.
No, you can use air also. I don't say that that is a wrong also, because the people, they are using air also. But SF6, only thing is that it remains for a longer time, so it gives you much better success. Thank you.
Uma, anything else? Uma, you're muted.
Yeah, sorry. Sridevi, you want to say something? No?
Unmute.
Go to the next case then, Ajay.
Yeah, please.
The next case, Sridevi, can you share your screen?
Yes, ma'am. Is it visible, ma'am?
Visible.
Yeah.
Sridevi. Good.
I'm audible too?
Yes, you're very well audible.
Okay. A very good evening to one and all. At the outset, I would like to thank the Noida Ophthalmic Society for giving me this opportunity. And after the brainstorming session on AI and EK, I would like to present my case, that is a case of molten metal burns and his journey with me so far. So a 48-year-old gentleman, an industrial worker, presented to me with history of pain, redness, and diminution of vision in the left eye since one day. He gave history of molten aluminum fall at the workplace due to accidental spillage, and he was attended immediately at the first aid department in the factory, and he was given immediate thorough saline wash, followed by installation of antibiotic and cycloplegic eye drop. There was no history of any pre-existing ocular or systemic morbidity. On examination, his visual acuity in the right eye was 6/6, whereas in the left eye, it was reduced to counting fingers close to face. And anterior segment structures in the right eye were absolutely normal, whereas in the left eye, the lids were edematous and charred with surface excoriation. And the conjunctiva showed circumcorneal pallor and blanching of the limbal vessels, almost more than 270 degrees, that is from 12 o'clock to 10 o'clock. And the cornea was showed near total epithelial defect, and with stromal edema and deep stromal folds. The anterior chamber was hazy, so the reaction could not be assessed. And the iris was normal in color pattern, and the pupil was mid-dilated due to cycloplegic effect. The lens was clear, and the fundus details could not be visualized. Our examination findings were validated on the basis of fluorescein staining pattern showing near total corneal epithelial defect and circumcorneal conjunctival defect as well. B scan in the left eye showed anechoic vitreous cavity and a normal optic nerve edge shadow, and the RCS complex was also normal, and there was no evidence of any choroidal detachment. So we diagnosed the patient as grade 5 ocular thermal injury in the left eye, and started him on topical steroids, that is 1% prednisolone acetate eye drop 8 times a day, and topical preservative-free moxifloxacin 0.5% 4 times, along with cycloplegics and preservative-free lubricants, and oral doxycycline to prevent stromal thinning, and oral diclofenac and serratiopeptidase combination, so as to reduce the periocular edema as well as pain. So after 3 days, when he presented to me, he had developed necrosis of the perilimbal conjunctiva, and the sclera was exposed. So at this point, my goal was to debride the necrotic tissue and restore the vascular supply of the ischemic sclera and hasten the surface reepithelialization so as to prevent secondary infection and of course, reduce surface inflammation. So I went ahead and did tenonplasty, that is Tenon's advancement with amniotic membrane transplantation. So here, under local anesthesia, so giving stay sutures over the lids, we separated the lids and then debrided the perilimbal necrotic conjunctiva and giving so perilimbal conjunctiva here was debrided and two nicks here in the viable conjunctiva at 3 o'clock and 9 o'clock position, and then did a blunt dissection of the underlying tenons, both superiorly and inferiorly, and then advanced it towards the limbus and then anchored it to the episclera at 3 o'clock and 9 o'clock position, just to cover the sclera so as to restore the vascular supply. And the cornea was covered with a human amniotic membrane with the epithelial side up, and it was sutured to the limbus with in a purse string fashion with tenno nylon. And after 15 days, however, there was a persistent epithelial defect inferiorly, and there was early disintegration of the amniotic membrane as well due to inflammation. However, instead of repeating the amniotic membrane transplantation again, I did a lateral tarsorrhaphy, and after a week, he healed pretty nicely with minimal scarring. And however, there was notable limbal stem cell deficiency, but since the visual axis was spared, he maintained a vision of 6/12. So this is how it appeared at 3 months follow-up. And as we can see, there's a progressive pannus, but since the tarsal conjunctiva and the fornice is not much involved, there was no symblepharon as of now. And there was a advancing pannus, as we can see the blood vessels advancing, and the conjunctival epithelium also, as well as we can see there's a very notable LSCD, almost 10 clock hours. And so waiting for adequate suppression of inflammation so that we can plan simple limbal epithelial transplantation to address the LSCD. So drawing parallels from various case reports worldwide, I assume that our management strategies have been very much in sync with other groups. And just to give a brief overview of ocular thermal burns, as they are little more uncommon than the chemical injuries. Thermal burns result from accidents associated with firework explosions or accidental spillage of steam, boiling water, or molten metal, especially aluminum in industries. And it's a true ocular emergency and can have potentially blinding ocular complications. And thermal injuries cause more severe form of limbal stem cell damage, and the extent of surface damage again depends on the temperature of the agent and the heat retaining capacity of the material, the duration, and the area of contact. So the extent of damage can be assessed according to the Roper Hall classification, which was used initially universally, but of late, more recently, we are using the Dua's classification to prognosticate the thermal injuries. And depending upon the grades, we can tailor our management strategies. And so more or less, the management strategies would remain the same as we have used. But however, in the later stages, we will need to address the lid deformities due to scarring and cicatrization. They could be cicatricial ectropion, or lag of thalamus. And LSCD has, the SLET is the answer to all the LSCDs. And partial, and depending upon the outcome of SLET, again, and the depth of scarring, we can decide whether he needs a full thickness or a partial thickness keratoplasty. And in cases with total bilateral LSCDs, K-Pro would be essential. So the sequelae here, early post-operatively, it could be like if we had left the sclera unaddressed, there could have been scleral ischemia and scleral melt and thus globe perforation. And if there was a persistent defect, a corneal epithelial defect, it would either go for corneal melt and perforation or secondary infection. However, in the late stages, there could be partial or total LSCDs depending upon the extent of damage. And symblepharon, if there's more of tarsal conjunctival involvement, and fibrovascular pannus, cicatricial entropion, secondary glaucoma, especially seen in alkali injuries if there's damage to the trabecular meshwork. And in extreme cases, the eye could go into phthisis as well. So why I chose to present this case was to highlight the importance of timely intervention, because it can stabilize the ocular surface and restore the structural integrity, and also promote faster reepithelialization of to prevent corneal scleral melt, and also prevent secondary infection and reduce inflammation and minimize scarring. Thank you, and over to the expert panel for any comments.
Thank you so much, Sridevi. A very nice case, and you have managed extremely well. Waiting for SLET, you said. My only small question is, you did not use vitamin C, or I didn't see, missed it in your medical management?
While going through the literature, I realized vitamin C in thermal injuries will not be very much essential, because there's not much of trabecular meshwork damage. So the aqueous levels of ascorbate are not much affected in thermal injuries, more in alkali injuries. But no harm in
it helps collagen build up anyway, and like your doxy prevents melting. What would you say, Dr. Samar and Dr. Goel?
Dr. Sridevi, can you answer?
Actually, what I feel is that the tenoplasty which she has done was the best decision. Actually, otherwise the cornea would have melted, or even the sclera would have gone. So the eye might have gone into phthisis bulbi, because molten metal injuries, they are very serious, and usually they result into phthisis bulbi. But she has been able to maintain the globe. That is a very big achievement. Of course, with SLET, of course, she will get good vision. But Dr. Samar may be able
No. Perfectly managed. Right
very
management.
nice.
Very right management.
Thank you.
Canoplasty with amniotic membrane is the right choice, and later on tarsorrhaphy, the simple procedure actually saved rather than redo the amniotic membrane or other type of surgery. Both the things are perfectly done nice. And regarding vitamin C, nothing harm in this way, because we know there are role of vitamin C for collagen synthesis. There are stromal involvement in this particular case also, not only epithelium, and stromal haze is also there. So probably SLET, you have to do a good anti-segment OCT to see the stromal haziness, that because of stromal scarring. If it is due to stromal scarring, you can wait and watch this patient for a longer period of time, because SLET will not probably the improvement of the vision. But if the PANAS goes, or it a real symblepharon formation, then you have to do with symblepharon release along with SLET procedure. Otherwise, perfectly managed case, ideal case.
Thank you, Sridevi. Nice case. Now, shall we go to Jyoti for your case? Terian's marginal degeneration. Jyoti is a senior cataract, cornea, and refractive surgeon. She's an excellent surgeon and a very good clinician, very sympathetic and empathetic. And I would like Jyoti to go on with her case.
Thank you, ma'am. Thank you for the kind words.
Jyoti, go to slideshow.
Yeah, so I've shared the slide. Can you see the slide?
Yeah, we can.
Okay. Good evening, everyone. Thank you, Nas, for the opportunity. So I would be talking about how we approach the two cases of Terian's marginal degeneration. Just the approach, how, in the two cases which presented to us in a different scenario. And the key to manage these cases is to have a customized approach for every case of Terian's that comes based on the stage of their presentation. And it's important that there are other peripheral ectatic disorders like pellicidal marginal degeneration, PUK, Murans, furrow degeneration. It has to be differentiated from all of these. The cardinal feature of absence of pain and inflammation along with the intact epithelium in the area of thinning with lipid deposits and vascularization help us to distinguish it from other peripheral disorders. And because follow-up of these cases is extremely important, but because progression is common, and ASOCT is a very sensitive tool in depicting the progression in these cases, which is the thinning. The area of thinning in these cases is marked by hyperreflectivity in that area. And also we can calculate the epithelial as well as stromal thickening separately. So that gives us an idea how the this thing is progressing. There is, and also the slit lamp photography. It gives an idea how accurately if there are any slight changes in the corneal pathology, they can be accurately mapped with the slit lamp photography. So this is a serial slit lamp photography of our patient. The patient presented to us in 2014. He was a 42-year-old chap, which is the average age of a patient of Tyrrhen's marginal degeneration that will present to us. The patient had no visual complaints. He did just had complaints of the color changes in the periphery of the cornea. So on slit lamp examination, we could see that there is peripheral thinning along with the lipid deposits in the anterior margin of the anterior margin of that thinning. And the thinning was involving almost 3/4 of the circumference of the cornea. And on subsequent slit lamp photography, we can see how there has been a confluence of lipid deposits. And even apart from the progression in the stromal thinning, there was more the encroachment of the stromal scarring area towards center is also seen to be progressing. In 2021, apart from the gradual progression which was happening in the periphery, in the superior area, there was an extremely ectatic bulge, which with the posterior cornea surface, posterior cornea bulging forward. So we did a ASOCT for the same area, showed an extremely bulge of the posterior corneal stroma, and also the stromal thickness here was around 130 microns. Apart from the the epithelial thickness was around 56 to 60 microns. So we can see how in the ASOCT, the serial ASOCT gives us an idea how it progresses. In the initial phases in 2014, there was this area of hyperreflectivity in the area of stromal scarring. And it slowly in 2017, how there is a concavity in the anterior curvature because of the stromal scarring and thinning. And in 2021, when he came for the last follow-up visit, there was extreme thinning. The patient was an outpatient staying in Raipur. He visits Noida every year and visits us for the eye examination. Interestingly, all these years, even despite the progression of the disease in the periphery, he has maintained good vision of around 6/6 and 6/9. And there was no cylinder, no astigmatism in 2014, but which has increased to 3.5 diopters in 2021. And though he maintained good spectacle vision, but because the cornea was locally very ectatic, we plan to do a banana lamellar graft in that area. It was to give the tectonic support to that locally ectatic area. And the banana graft was harvested on the donor cornea, mounted on an artificial chamber with the stenciling based prick and print method. So now, though the cylinder, it's 2 months post surgery, though the cylinder of the patient has increased as compared to what it was pre-operatively, but at least there is a tissue that has been added to the peripheral thinning, and chances of spontaneous perforation are less. Now, the second patient, he had a bilateral disease as compared to the previous patient, which had a unilateral disease. We were he presented to us in 2011. The right eye had early disease, though it has early disease, and in the left eye it was advanced. The uncorrected visual acuity was 460, which improved to 6/12 by RGP trial, and he was dispensed the RGP lenses. On the follow-up visit in 2016, he didn't come for the follow-up in the intermediate years. And in 2016, he came with the circumferential thinning, 360-degree thinning, with a small leak in the periphery, for which a palliative procedure of cyanoacrylate glue application with BCL was given, and then followed by an annular lamella. This is the area of circumferential thinning with a little pseudoterigum that has been formed here, and then the annular graft was done, which was augmented by amniotic membrane grafting and tarsorrhaphy to enhance the epithelial healing. Now, on the other side of the spectrum of these kind of cases is something like this. The patient which came up, it is a pictures. These are the pictures of ASOCT and the slit lamp photo of a 20-year-old male who didn't come to us for any complaints. He just came for a routine eye examination. On elevating the upper lid, we could see that there is a peripheral thinning and the lipid deposits along the anterior margin of that thinned area. So it's important that here, because we with the early diagnosis, it's important. It's helpful that we can educate our patient regarding the progressive nature of the disease here at this level, because the patient was 6/6. There's significant corneal tissue here, so we didn't do any intervention. We just educate him regarding the progressive nature of the disease, and to follow up on a regular basis to see for progression. Thank you. So I would want my the seniors here. How could we have whether we could we do the things differently in this case, and how to share their experience regarding such cases of Tedious marginal degeneration.
Dr. Samar, any and Dr. Goel on the other panelists, should we?
Dr. Rohit Shetty has been quiet. We would want
Dr. Rohit, are you there?
No, he might have.
Okay, Dr. Samar, please.
No, first case, yeah, that one is managed nicely. So you have to check as the cornea is thinning in this, and you could follow up this case for little longer, because the banana graft, unless it is perfectly done, sometimes it may melt. So that is why the corneal thickness, what I understood, that epithelium is around 60, stroma and endothelium another 130. So around 200 micron in the periphery, in the upper part, less traumatic zone. And the patient is having not that much vision, like 6/9 with minus 3.5 diopter per cylinder. So that way he was doing good. But only thing that we need to know how the follow-up of this patient is going on for next 1 year, 2 years, 3 years down the line, because it is not a regional part, all 360 degrees involved in the first case.
Right.
So you have to be very careful in attempting these cases. Second case is perfectly, because it has microperforation, you have done emergency glue, later on you have to do annular graft. And this patient, because of annular nature of the graft, this graft survival and the treatment rather easier, rather than a small banana graft in a 360-degree terion with a sectorial, you are doing only sector, then the difficulty comes. If it is only upper part terion, thinning, extreme thinning, just epithelium and DM endothelium, so you could do sectorial terion, sectorial banana graft in those cases. But when 360-degree involved, suturing is difficult because other part is also thinned out. No? So suturing, there may be chance of chisoiding, and later on, the problem will happen that the graft, because of the surrounding tissue is not good, the graft tends to melt in those cases. But for annular graft, the second one, there is no question of this. You do nice peritomy and you do suturing. Only you have to do nice suturing because you have to do double suturing in these cases.
The only consideration
But-
which I thought was because the patient is not, I mean, COVID times one, the second was the patient was an outstation patient. So that was, but yes, as you said, I mean, that was my, I mean,
Follow-up is important in this, how the patient is doing in this particular, because it is a progressive disease, no? One part you have rectified, the other part will same thing will
continue.
happen with times. And then what will happen? How do we manage those cases?
And
So these are the question with the first case, but second one, as I said, it is.
Dr. Samar, some
Yeah.
people who large lamellar with till can all know, tuck in lamellar and stuff to spare the limbal cells. How do you feel about that? Large dull, whatever.
Large dull is not necessary normally in Terriens. Terriens, that way, Terriens is not that bad kind of degeneration. Many patient remains in the same situation for many years, unless there are few cases where maybe there are some inflammatory elements are there, though these are not inflammatory. So you can do tuck-in in those cases like tuck-in in keratoglobus patient, tuck-in DALK type. So I mean partial thickness annular graft with tuck-in technique so that you could preserve some of the, but large bulk I do not know whether it is required or not, because central cornea is absolutely normal.
Right. So just annular would be okay.
Annular, yes, annular tucked in, you can do it. I have done 2, 3, but these are not many cases. We don't see
They are
many.
not very common, basically.
Very uncommon. Probably in 10 years' time, you will be doing 3, 4
True.
like
Dr.
that.
Goel, you're saying
No,
something?
Cricentric graft I have seen, but actually that also, as Dr. Basak has pointed out, so that got melted away. Actually, it was retained for a month or so, and then it got melted. Because once you are putting the graft over the lamellar cornea or very thinned out cornea, one thing is that suturing, as Dr. Basak also has pointed out, it's a difficult. Suturing both sides, on the scleral side also, where the chances of necrosis are there, the sutures also, they will get loosened up and then they might go. And on the central side, of course, it's a difficult that you are worried about the pupillary zone. And the vision in these patients is, as you have also pointed out, the vision is very good. And what I feel is that I am a conservative person. So even if the cornea is thinned up to 100 micron or 150 micron, we will not touch these patients for surgery. Because even if the whatever worst can happen is that perforation, as you had shown in the second case, that time you can do, because if the patient's vision is good and you have done lamellar graft, and because of high astigmatism his vision goes down to 6/60, then he might pull you in the court also. Because these type of patients, sometimes these patients, you don't know the behavior, what will happen afterwards. So that is why, because these days we have to be a bit scared of CPA also. So,
True enough.
Okay.
okay.
Shall we go to our last case, Ajay?
Yeah, please.
Dr. Piyush Tiwari is a very talented young upcoming corneal surgeon who will present a case of limbal dermoid, which he has managed with a lamellar graft. Dr. Piyush?
Good evening. Thank you, ma'am. Thank you for the kind words. And first of all, good evening to all of you. And I would like to thank Dr. Ajay Arora for organizing such a nice meeting, and Noida Ophthalmic Society. I'll thank my mentor also, Dr. Rohit Shetty, who has been a exceptionally motivational and driving force behind all the fellows. And I'll start my case by discussing a case of limbal dermoid. I just want to know,
Can you
is
share
my
your
screen visible?
No,
No,
not
my
yet.
Piyush, not yet. Can you share your screen?
Yeah, ma'am, just a second. I think, yeah.
Are you sharing, Piyush?
Yes, ma'am, I'm just sharing. Okay. It's asking me to, 1 second, I'll just.
So while he is sharing his screen, okay, he is connected again.
Yeah, he's connecting, Ajay.
No, I've been.
You can share your video.
So yeah, actually now it is connected. So
But
is my screen visible, sir?
Not yet, not yet.
no, Piyush, you are visible, not your screen.
Okay.
Yeah.
Now is it visible?
visible. Yeah.
Yes, it is visible.
Actually, there was some glitch.
Okay.
Okay,
Go
so
ahead.
so the last presentation of the day, I think everybody is too tired now. So I'll show a video of my surgical management of limbal dermoid. So like limbal dermoids are choristomas. Basically, they contain variety of tissue elements like fat, hair, bone, and teeth. And this case was a classical localized limbal dermoid, not extending into the fornix or the lateral canthus. So we did not do an MRI. And in this case, typically I had a few challenges. It was like the depth assessment in dissection, corneal scleral dissection itself, the construction of the graft, and the suturing. So I'll just straight away jump to the corneal surgery. In this surgery, the main plan was to excise the whole limbal dermoid, and I intended to do as deep dissection as possible. So I've already placed a 6.5 millimeters of mark using a Trifine. So it's a very superficial mark, and I'm extending it with the crescent blade. And initially, I'm trying to do a superficial dissection, and I'm trying to cover, all the as much of the dermoid tissue as possible. This tissue it was sent for the histopathological evaluation. It was ectodermal. It was ectodermal in origin. Can you hear me?
Yeah.
Yes,
Yeah,
you can
okay.
hear the Piyush.
Okay. So the dissection itself was it was a Tenon's. It was very thick,
Please mute it.
and it was very entangled with the whole scleral tissue. It was quite tough, and to be very honest, I did not actually imagine it to be very well adhered to the sclera. So I finally had to use a sheer force to just get it out of the scleral tissue. There were a couple of bleeders, and we cauterized the bleeders. So this is the whole limbal dermoid coming out, but this is the superficial dissection. Then we found the deeper plane and dissected almost up till 300 microns, and it was fairly deep. This time we could get a nice plane, and the whole dermoid was removed in toto. So the corneal and scleral complex is looking really thin, and we can actually see if you can carefully see, we can see the trabecular meshwork as well. So it's almost like a trabeculectomy seen from the beneath. Then we cauterized, and the bleeders were cauterized properly. Now the third difficulty was the patch graft construction. And initially I did not gave a very particular thought on how to align the limbus from the host to the cornea, and I just made a punch, and it was clearly wrong because the alignment wasn't getting correct. So I took the whole graft, the limbal button, and put it over the area where I had to take the graft, and then I re-punched the whole scleral corneal complex. And then the final issue was the suturing. So this was typically tough because the host bed was lamellar in thickness, and I was trying to implant a donor which was a full thickness graft, and I could not find any way to make the graft also in a lamellar way. So I used a 10-0 nylon suture on the corneal side, and in the limbal side I used a 6-0 vicryl. Suturing was very tough actually, and finally the whole conjunctiva was closed with a 7-0 vicryl suture. This case was done under local anesthesia. This was 23 years old girl, and this was the post-op result. And now we are planning to do a scleral contact lens, Boston scleral contact lens, or maybe topo-guided procedure that we'll have to figure out. Not decided as yet. But she's holding a visual acuity of 6/12 with pinhole. So thank you. I would like to accept comments and different ways of approaching the same condition. So please, the seniors can guide.
Can you stop sharing your screen, Piyush?
Yeah,
Actually, may I say one thing? One we have tried is like Dr. Samar has done is dissection. Now we have used the upper part for the lower part for endothelial and the upper part for this limbal dermoid. We have used cornea in the scleral part also. That we have done. One is we have tried to glue the corneal part and suture in the scleral part. We have tried that too. The other thing is if the color, I mean, if you have not completely dissected, we have tattooed also underneath the lamellar graft. So we have tried all these things. Sometimes it's not so deep, so we have used AMG also. So these are the different techniques we have tried for limbal dermoid. Dr. Samar, Dr. Goel, Surbhi, Sridevi, Jyoti.
Was it a corneoscleral graft or it's just a cornea placed over the sclera also?
Cornea over the sclera also, sir. They have placed because it's collagen that you are replacing. So it's transparent enough. So it's cosmetically also, it is all right because you're covering it with a conch. And
ma'am, actually, I did think about doing that also, but the main issue was that at least I did not review a lot of literature on that. But I felt that if we are, replacing a limbal tissue, so we have to at least give a limbal tissue there, because practically we are dissecting through the limbus. Almost 50% of the limbus is gone. So it might lead to.
How much of the LSCD you are actually replacing with the sclera? I am a little doubtful about that, but the experts.
So actually, that was a relatively dicey for me also. So I was thinking on those lines, but then thought maybe replace the limbus.
Cornea on a partial thickness bed,
Yeah, it wasn't. I was not very fond to do it, but then there was no other option at that point.
Keep it on an artificial chamber, like Jyoti said, stencil procedure, or you can take a lamellar dissection on the artificial chamber. So you can do it with a guarded knife and a nice thing you can get there. You can get that lamellar, and you can make it even corneoscleral if you're placing it in that. If you're that concerned.
Yeah, if we get a large rim, if we get.
Yeah, you can dissect the sclera also in a lamellar fashion and put it there.
Oma, this glue was working very well even in Scotland.
It does, like in a bare bed, see, Falk we have done without, in the Femto we have done without glue also. And up till 250 microns we have done without glue, because Femto preparation of the thing makes it very sticky. So when you take that anterior 250, even 300 microns, we have been able to stick without glue, without sutures. In this, we can use this one, what do you call it? Fibrin glue, and it does
Glue.
stick. Yeah.
I
And you can
thought
just
that
the scleral side. In the like femto, we use without glue up till 250 microns.
Can we
Because
have
it-
Dr. Summers' views on this?
yeah,
I
sure, sure.
think only comment is that full thickness versus partial thickness. And during suturing, when you are doing a sclerocorneal one, cornea is also nicely can be done, and there is no problem. But when you try to match the limbus to limbus, the first two sutures used to give like you match the limbus. That is one thing I follow. Then the dissection, I think dissection level, you just debulk the tissue. So you first debulk the tissue, then you do trephine. Your trephination will be much, much perfect. When you do with an elevated large dermoid, then first debulk the tissue, little cautery of using vessels. Now you do trephination. You can do actually good trephination, like we do in manual bulk, like up to 300 micron, you can do trephination. Then your dissection plane will be much more perfect, and you will be much more smoother dissection. Then you can go deeper and deeper. And one thing in in this group of cases, if you get a chance of doing gonioscopy, sometimes you may reach the angle during dissection. You are aggressive enough, you go a little deeper and deeper and deeper, and you might find that the dermoid has a tail in the angle. So if you get a chance of doing off angle photography, in many cases we have seen the angle is involved. There you have to be very careful. Only superficial dissection. May not be, and do little tattooing with amniotic membrane graft, that will serve the cosmetic purpose. But you should not invade the angle. So these are little thoughts about this, Gerard.
That's an excellent point.
Thank you, sir. Very, very insightful, actually.
UBM should have been done, no?
Yes, yes.
Yes, sir.
That's why
UBM
the
could have been
angle,
done.
because you cannot put the gonioscope rightly unless it is a small
Exactly.
one. Then UBM really helps in this group.
Dr. Sama, just a question. These days people do intra-op OCT. So does an intra-op anti-segment OCT help here?
Intra-op OCT, IOCT.
Yeah.
Roll up intra-op OCT,
In
yes.
this particular case, when you're
case,
doing a
yes,
dissection.
yes. So when you are dissecting very nicely, then at that point it can show you actually what depth you are, what is the minimum, how much you can dissect more. All these answers will be coming. But again, the management in this case, suppose if you see a child, you insist that you should do operation before embryogenic age. So before 6 years of their life, if you do, then you have to rehabilitate for amblyopia therapy, then this will be your complete therapy. But in a 23 years old, this is purely for cosmetic reason. So something as the vision will never improve more than 612.
There was a
And
paper, Ajay, on that you were saying, na, dermoid with this. I think Namrata's group had published at IJO. I was one of the
Yes.
reviewers. I think they had published in IJO, same thing, OCT, intra-op OCT aided dissection. I think they do intra-op in everything, like even field
They
ulcer,
have the
everything.
facility, and they have in each OT, they have one.
They have
I
four,
think
huh? They have four of HDO.
No, I was trying to demonstrate my limited corneal knowledge.
No.
You have excellent knowledge,
You
Ajay.
have nice knowledge, Ajay.
You have widespread knowledge.
Pan ophthalmologist.
I'm really thankful to, I think we will put a close to things, and I have to share the video, so bear with me. But before I share the video, must thank Dr. Samar and Dr. Rohit Shetty for agreeing to be part of the Noida Film Society webinar today. It's been an honor to have you both We feel so happy that with over a period of last 6-7 months, Noida Film Society has been consistently doing good webinars. We've been having good speakers, and the academic level has gone up. And thankful to the panelists who have been associated, Dr. Shreedevi, Dr. Surabhi, Dr. Jyoti, Dr. Piyush, and I've been badgering Uma for last many weeks in making this program and putting it together. And Uma was insisting that she wanted to hear Ek Safar from Dr. Samar. So we insisted on this paradigm of thing of the past and the future, and it has beautifully gelled together.
I think Dr. Rohit took us
Yeah,
on a
yeah,
time
yeah.
machine into the future.
Yeah.
And
It's
it's
so
amazing
futuristic.
what they are doing. In fact, I
Yeah,
tell
yeah.
all my residents, I've heard Dr. Rohit at LVP and all, and his story about finding VEGF in the tear film. And every refractive case, they are taking the Shermers, storing it, going back to it when something has gone wrong or something like that. And then his story about someone who had high VEGF turned out to be a carcinoma. Am I okay with sharing that story, Dr. Rohit? I'm sorry.
Yeah, absolutely. And I mean, that's been, I mean, it's not one. I mean, at that point of time, I remember it was 2018, I think Dr. Sayan had called and I spoke about it. We have at least 4 or 5 cases where we have figured out unusual high levels of VEGF and which you couldn't explain. And later, after a year or two, most of them, at least 2 of them have come back with some cancers somewhere. So I'm very sure that in the next 5 years, tears would be an area of widespread research in cancer biology. And I have no doubt that, see, because it's the same fluid when a lot of things are secreted, and it's just that it's picking up easier.
So thank you. Anybody wants to say anything? Dr. Goel, sir?
Thank you. It was nice discussion.
While Dr. Goel was senior resident for Dr. Samar, he was a consultant for me when I was in different Pondicherry. So he had come from RPC and he was my teacher. So thank you, Dr. Goel, for being there. And I always can depend upon him. And thanks, Dr. Atul. I'm very happy that we have Dr. Survi and Shridevi who are working with us. And, we have very young, dynamic cornea surgeons in Noida. So thank you all very much. So bear with me for these 2 minutes. We have to thank our sponsors. So I'll just share my screen for their video. Just 1 second.
Your doctor enhancing your eye care practice is the sole reason why we bring to you latest advancements in ophthalmology. Tear, hyperosmolarity, and a chain of inflammatory events create a vicious cycle that perpetuates the dry eye disease state. To heal dry eye effectively, we present to you Soha, the natural healer for dry eyes. Soha has the unique formulation containing combination of sodium hyaluronate and osmoprotectants, especially L-carnitine, erythritol, and glycerine. Use to 2017 Use to report acknowledged that a new alpha formulation that contains hyaluronic acid antivirals has been developed to capitalize on lubricant properties of hyaluronic acid and bright protecting properties of antivirals. To heal moderate to severe dry eye effectively, we present to you Soha Liquid Gel, natural protection that lasts long. Soha Liquid Gel has unique formulation containing sodium hyaluronate, trihalols, and cardamom. Sodium hyaluronate with hygroscopic and neuroadhesive property spreads evenly on the surface of the eye and provides a protective coat over cornea. Providers with bioprotective
இன்னைக்கு அந்த இது
stabilizes the lipid bilayer and prevents the denaturation of proteins under osmotic stress conditions. Carbover is a viscosity enhancer and prolongs ocular retention time, which results into lower installation frequency. Innovative manufacturing process of sodium hyaluronate in soha and in sodium liquid gel does not involve any animal protein, rather uses fermentation of Streptococcus zooepidemicus. Hence, soha and soha liquid gel is free from animal protein. Available in medical stores near you in 5 ml and 10 ml drops.
So thank you all very much for.
Thank you. I think without your perseverance, all these 8 meetings would not have taken place.
No,
So,
I'm enjoying it.
it's great.
I'm enjoying and I'm very happy that it is making a good fellowship amongst all of us. There's a lot of friendship. There's a lot of interaction, and the academic atmosphere in Noida is improving. And with Uma and Reena, we are starting a newsletter. So all of you will be getting a Noida newsletter soon. We wanted to launch it today, but we are not yet ready for it. But hopefully by the next meeting, we'll be able to launch it. We are aiming it to be like the DOS Times, and with Uma always insisting on getting the journal out, I think we should be able to achieve. So I would encourage all the delegates, all the Noida members to participate actively in our academy. So
And
thank you all
Samar
once
sir, once more, best of luck for your election.
Yeah.
Thank you. Thank you.
Yeah. So
And thank you very much for joining here, and we learned a lot.
Really kind. Thank you, Dr. Rohit sir. So good night, stay healthy, stay safe.
Okay. Good night.
Good night, sir. Thank you.